Good day, everyone. I would like to extend my warmest greetings to each and every one of you. I am thrilled to be here today to talk about drugs that affect the peripheral nervous system. Before we begin, I would like to give a special shout out to our Sir Ryu Malao, RCIN Pharmacology, for his unwavering support and guidance. Now, I understand that some of these concepts we'll be discussing might seem difficult to grasp, but please bear with us. We've worked hard to make this presentation as clear, as comprehensive as possible. We'll cover everything from the basics to the more complex aspects, so you can expect to leave this presentation with a thorough understanding of the topic. Joining me in this presentation is my partner Giselle Abella. Together, we'll do our best to answer any questions you may have along the way. So, sit tight, relax, and get ready to learn. Our presentation covers neuropharmacology basics, PNS physiology, and drugs affecting the nervous system, muscarinic cholinesterase inhibitors, nicotinic blockers, adrenergic drugs, and antagonists, and indirect anti-adrenergic drugs. Now, this is the boiling question we have today. What is neuropharmacology? Just by looking the word, neuro means the nerve, and pharmacology means the study of drugs. Therefore, neuropharmacology is studying drugs of the nervous system. Now, why do we have so many neuropharmacologic drugs? Neuropharmacologic drugs exist because the nervous system regulates mainly bodily processes, which can be modified by drugs that mimic or block neuronal regulation. These drugs can affect a wide range of bodily functions, including muscle contraction, cardiac output, and glandular secretion, as well as unique functions of the CNS like mood and pain perception. Looks like we meet again. Axonal conduction and synaptic transmission. Basic anatomy. I admit it. I almost forgot about it. Axonal conduction is simply the process of conducting an action potential down the axon of the neuron, while synaptic transmission is a process by which information is carried across the gap between the neuron and postsynaptic. Confused? Axonal conduction is like an electrical signal traveling down the wire in a neuron. This signal travels down the axon. Synaptic transmission is like passing a message from one person to another. In a neuron, the message is passed from the end of one neuron, the presynaptic cell, to the beginning of another neuron, the postsynaptic cell. The five steps of synaptic transmission are transmitter synthesis, which produces neurotransmitter, transmitter storage, which stores neurotransmitter in vesicles, transmitter release, which releases neurotransmitter, receptor binding, which binds to specific receptors, and termination of transmission, which can be broken down or reabsorbed. Drugs can affect receptor activation in synaptic transmission in various ways, including increasing or decreasing transmitter synthesis, promoting or impeding storage and release, acting as agonist or antagonist, binding to receptors, blocking uptake, and inhibiting degradation. These actions can either increase or decrease receptor activation. For further information, please refer on Table 12.1 and pause. Thank you. The scenario presents the idea that if a person becomes sick and needs medication to regulate their body back to normal, having a variety of receptors can help produce selective drug effects. So, if all receptors were the same, different body organs would be affected by the medication, potentially causing unwanted side effects. However, if there are different types of receptors, like in the case of MERV, It can help prevent interference with other organs and increase the chances of producing selective drug effects. In summary, having more types of receptors can increase the effectiveness and specificity of drugs in treating illness. This photo explains the different branches of the nervous system. So, as you can see here, this is the branches of the nervous system. Here we have three principal functions of the ANS: regulating of the heart, secretion glands, and smooth muscles. On this portion, we can see different functions of PNS and ANS. Please pause and take your time to familiarize with it. When we encounter a stressful situation, the sympathetic nervous system triggers the fight or flight response. This response includes increasing heart rate and blood pressure, diverting blood from skin and viscera to skeletal muscles, dilating bronchi to improve oxygenation, dilating pupils for better visual acuity, and mobilizing stored energy to provide glucose for the brain and fatty acids for the muscles. This passage discusses the different types of innervation by the autonomic nervous system. The first type involves both the sympathetic and parasympathetic divisions having opposing effects, while the second type involves the divisions having complementary effects. The third type involves only one division of the autonomic nervous system being responsible for innervation and regulation. Feedback regulation is a process where a system adjusts itself by responding to incoming information. Most physiologic processes are regulated through feedback control. The most important feedback loop in the autonomic nervous system helps regulate blood pressure, which is called baroreceptor reflex. Autonomic tone refers to the background level of activity of the autonomic nervous system that maintains organ system function. Predominant tone refers to the higher baseline activity level of either the sympathetic or the parasympathetic division in a particular organ or tissue. Acetylcholine, norepinephrine, and epinephrine are three important neurotransmitters or chemicals that are involved in the functioning of the nervous system. Acetylcholine is the primary neurotransmitter of the parasympathetic nervous system, which is responsible for rest and digest activities in the blood. It is also involved in learning, memory, and muscle movement. Acetylcholine is synthesized and released by cholinergic neurons, and it binds to specific receptors to elicit its effects. Norepinephrine, also known as noradrenaline, is a neurotransmitter and hormone that is produced by the sympathetic nervous system, which is responsible for the fight or flight response in the body. Norepinephrine is released by noradrenergic neurons and acts on adrenergic receptors, including alpha and beta receptors. It increases heart rate, blood pressure, blood sugar levels, and also causes vasoconstriction. Epinephrine, also known as adrenaline, is a hormone and neurotransmitter that is released by the adrenal glands and acts on adrenergic receptors. Like norepinephrine, it is involved in the fight or flight response and increases heart rate, blood pressure, and blood sugar levels. However, epinephrine also causes bronchodilation and relaxation of muscles in certain organs, such as the lungs, to increase oxygen intake. Cholinergic receptors are receptors that bind to the neurotransmitter acetylcholine, while adrenergic receptors are receptors that bind to the neurotransmitters norepinephrine and epinephrine. Cholinergic receptors can be further divided into nicotinic and muscarinic receptors, while adrenergic receptors can be further divided into alpha and beta receptors. These receptors play important role in regulating various physiological processes in the body, and drugs can be designed to selectively target these receptors for therapeutic purposes. This portion is a further example of the mort and nerve. This is what I'm talking about. Having different types of receptors can make a drug selective. In this portion, we can see how transmitters activate certain adrenergic transmitter. For epinephrine, all except dopamine. Norepinephrine, the alphas and beta 1. And dopamine, all except alpha and beta 2s. What we need to know about these categories of cholinergic drugs are their representative drugs. Please refer to table 14.1. Do not worry because we are going to discuss this in the following portions. We also have the table 14.2, cholinergic drugs and their receptors. Pause if you need to. Now, betainocol, betainocol is a direct-acting muscarinic agonist, which means it binds to muscarinic cholinergic receptors and activates them. It has selective effects on muscarinic receptors and little to no effect on nicotinic receptors. Its pharmacologic effects are mainly on the heart, exocrine glands, smooth muscles, and the eyes. The drug is administered orally and takes about 30 to 60 minutes to take effects. Its effects last for about an hour. Because betainocol is a quaternary ammonium compound, it poorly crosses membranes, resulting in only a small fraction of each dose being absorbed. Betainocol is mainly used for the treatment of urinary retention and also gastrointestinal disorders. However, betainocol can also cause adverse effects on various systems, including the cardiovascular, gastrointestinal, urinary tract, and respiratory systems. It may cause hypotension, bradycardia, excessive salivation, increased secretion of gastric acid, abdominal cramps, and diarrhea. Betainocol may also exacerbate asthma by causing bronchoconstriction and lead to dysrhythmias in patients with hyperthyroidism. As a result, it is contraindicated for such patients. Atropine is a muscarinic receptor antagonist. It blocks the effects of endogenous acetylcholine by competitively binding to muscarinic receptors. The pharmacologic effects of atropine include decreased salivation, bronchodilation, increased heart rate, mydriasis, and decreased gastrointestinal and urinary tract motility and nervous system stimulation. The effects of atropine are dose dependent, meaning that higher the dose produces more intense effects. Atropine can be administered topically to the eye or parenterally, which can be intramuscular, intravenously, or subcutaneously. It is rapidly absorbed and distributed to all tissues, including the central nervous system. Atropine is metabolized in the liver and eliminated in the urine with a half-life of approximately 3 hours. It is used for pre-anesthetic medication, disorder of the eyes, bradycardia, intestinal hypotonicity and hypermotility, and muscarinic agonist poisoning. Adverse effects of atropine include xerostomia, blurred vision, photophobia, elevation of intraocular pressure, urinary retention, constipation, anhidrosis, tachycardia, and asthma. So in this portion, we can take note of the summary of major nursing applications. So take time to pause. Cholinesterase inhibitors prevent acetylcholine degradation by acetylcholinesterase. There are two types, reversible and irreversible inhibitors, with reversible producing moderate effects and irreversible producing long-lasting effects. Neostigmine is a cholinesterase inhibitor that slows down the degradation of acetylcholine, producing effects that are similar to acetylcholine. It has muscarinic, neuromuscular, and central nervous system effects. Neostigmine can be administered via IM, IV, or sub-Q injection. and it is eliminated by enzymatic degradation by cholinesterase. It is used to treat myasthenia gravis and reverse competitive neuromuscular blockade. Adverse effects can include excessive muscarinic stimulation, leading to salivation, gastric secretions, increased GI motility, urinary urgency, bradycardia, and sweating, meiosis, and spasm of accommodation. So here are some mnemonics that you should be familiar when identifying dangerous conditions. Myasthenia gravis. MG is a neuromuscular disorder characterized by fluctuating muscle weakness and a predisposition to rapid fatigue. Common symptoms include ptosis, difficulty swallowing, and weakness of skeletal muscles. Cholinesterase inhibitors like mustigmine can provide symptomatic relief for myasthenia gravis by preventing the inactivation of acetylcholine, increasing muscle strength. However, they do not cure the condition and can cause side effects by accumulating acetylcholine at muscarinic junctions as well as at NMJs. Dosage adjustment can be challenging, and an optimal level of muscle function is achieved by administering small initial doses. So that's all for my part. Thank you. Giselle Abelong will be presenting the next chapters. Thank you. 16 minutes now.
Hello everyone, I am Gisela Belong and I will be the one to discuss the remaining 4 chapters of our topic, which is the peripheral nervous system drugs. So let's start with the drugs that block nicotinic cholinergic transmission or the neuromuscular blocking agents. So neuromuscular blocking agents prevent acetylcholine from activating nicotinic receptors on skeletal muscles, which results in muscle relaxation. So, acetylcholine is the chief neurotransmitter of the parasympathetic nervous system, the part of the autonomic nervous system, which is a branch of peripheral nervous system that contracts smooth muscles, dilated blood vessels, increased bodily secretions, and slows heart rate. These drugs are given to produce muscle relaxation during surgery, endotracheal intubation, mechanical ventilation, and other procedures. So, based on the mechanism of action, neuromuscular blockers fall into 2 major groups, which is the competitive non-depolarizing agents and depolarizing agents. So next we have the basic concept of polarization, depolarization, and repolarization. So for polarization, it is the uneven charge distribution, positive charges over the outer surface on the membrane and negative charges over the inner surfaces or surface. Next, we have the depolarization. It is the positive charges move from the outside to inside. So many positive charges move inward, then the outside of a membrane becomes more positive than the outside. And lastly, we have the repolarization. So it is accomplished by pumping positively charged ion out of the cell. It restores the original resting membrane state with positive charges on the outer surface and negative charges on the inner surface. Next, we have the tubocurarine. It is the oldest competitive neuromuscular blocker, were known to primitive hunters long before coming to the attention of scientists. So this drug is used to produce muscle relaxation. Its primarily clinical therapeutic use is the treatment of muscle spasm and immobility associated with sprains, injuries of the back, and to lesser degree injuries to the neck. So this drug is one of example of neuromuscular blocker agent that I am about to discuss. Next, we have the basic pharmacology of competitive non-depolarizing neuromuscular blockers. So, non-depolarizing neuromuscular blocker agents has a long-lasting duration. So, mechanism of action of these non-depolarizing neuromuscular blockers, competitive neuromuscular blockers do not result in receptor activation, but they do compete with acetylcholine for binding in nicotinic receptors on the motor end plate. They attach to the nicotinic receptors and prevent acetylcholine from activating the receptors, which relaxes the muscle. The medication can be removed from the body, or more acetylcholine can be added to neuromuscular junction to restore muscle function. Next, we have the pharmacologic effects, and these two are muscle relaxation and hypotension. Next, we have the pharmacokinetics. Within minutes of IV injection, paralysis sets in. Peak effects last for 20 to 45 minutes, and total recovery takes an hour. Depending on the substance being eliminated, the most frequent method include hepatic metabolism, renal excretion, plasma cholinesterase breakdown, and spontaneous degradation. Next is we have the therapeutic uses. So why does it need for surgery, mechanical ventilation, and endotracheal intubation? So for the surgery, it has three purposes. So first is to facilitate intubation, second to decrease patient movement, and last is to improve operating conditions for the surgeon. So next we have guys, we have mechanical ventilation. So for mechanical ventilation, it is used by blocking spontaneous respiratory movements or more frequently to provide more suitable condition for surgery. So mechanical ventilation, guys, is a form of life support that takes over the work of breathing when a person is not able to breathe enough on their own. So guys, commonly we call this as breathing machine. Next, we have the endotracheal intubation. Lastly, we have the endotracheal intubation. So for this one, NMBA or the neuromuscular blocker agent may decrease the incidence of hoarseness and vocal cord injuries during intubation and can facilitate mechanical ventilation in patients with poor lung compliance. Next, we have the adverse effect. So we have two adverse effects, which are the respiratory arrest and hypotension. So for respiratory arrest, it can result from respiratory muscle paralysis. Therefore, facilities for artificial ventilation must be available right away due to this risk. Next, we have the hypotension. One competitive agent, which is atracurium, can release a significant amount of histamine. So last, guys, is the precautions and contraindications. So we have the myasthenia gravis. So myasthenia gravis is a condition characterized by skeletal muscle weakness. So guys, next we have the properties of individual agents. So first we have the atracurium. So it is approved muscle relaxation during surgery, intubation, and mechanical ventilation. Next, it can cause hypotension secondary to histamine release. Third, it is eliminated by plasma cholinesterase. Fourth, it is desirable for patients with renal or hepatic dysfunction. Second, we have the cisatracurium. It is approved muscle relaxation also during surgery, intubation, and mechanical ventilation. So it is eliminated by spontaneous degradation, and then it is desirable with patients with renal or liver dysfunction. Next, we have the mevacurium or the mevacron. It is a short-acting skeletal muscle relaxant. It is approved for both inpatient and outpatient procedure requiring muscle relaxation for surgery, intubation, and mechanical ventilation. Next, histamine release is usually small. Next, we have the pancuronium. It is approved for muscle relaxation during general anesthesia, intubation, and mechanical ventilation. It does not cause histamine release, ganglionic blockade, or hypotension. Fifth, we have the rocuronium. It is approved muscle relaxation during surgery, intubation, and mechanical ventilation. Muscle relaxation begins in 1 to 3 minutes. It does not cause histamine release, eliminated by hepatic metabolism. And lastly, we have vicoronium. It is used for muscle relaxation during intubation, general anesthesia, and mechanical ventilation. Does not produce ganglionic or vagal plaque, and also does not release histamine. It is excreted primarily in bile. Therefore, paralysis may be prolonged in patients with liver dysfunction or greater weight. The next, guys, we have the depolarizing neuromuscular blocker or the succinylcholine. So the depolarizing NMDAs has a short duration compared to the non-depolarizing one. So for the mechanism of action, succinylcholine produces a state known as depolarizing neuromuscular blockade. Like acetylcholine, succinylcholine binds to nicotinic receptors on the end plate and thereby causes depolarization. So pharmacologic effects, first is muscle relaxation, second is the pharmacologic to the central nervous system. So the depolarizing effect of it to the central nervous system is that the drug can completely paralyze without decreasing the consciousness or the ability to feel pain. Next, we have the pharmacokinetics. So succinylcholine has an extremely short duration of action. Paralysis peaks about 1 minute after IV injection and fades completely 4 to 10 minutes later. So guys, next we have the therapeutic uses. So first, muscle relaxation during endotracheal intubation. Second, used to decrease the strength of muscle contraction during electroconvulsive therapy. Guys, next we have the adverse effect. So first, it prolonged apnea in patients with low pseudocholinesterase activity. Second, malignant hyperthermia. Third, postoperative muscle pain. And fourth, hyperkalemia. So guys, next, as you can see in the screen, it shows the properties of competitive and depolarizing neuromuscular blockers. So on the screen, we have the drug, which are the competitive agents and depolarizing agent. The route, time to maximum paralysis, duration of effective paralysis, time to nearly full spontaneous recovery, promotes histamine release, either it is a yes or a no or minimal. Then last, the primary mode of elimination. So guys, next we have the adrenergic agonist. So adrenergic agonists produce their effects by activating adrenergic receptors. So these drugs are used in many life-threatening conditions including cardiac arrest, shock, asthma attack, or allergic reaction. So guys, we have the chemical classification, which are the catecholamines versus non-catecholamines. So the catecholamines are so named because they contain a catechol group and an amine group. Second, because of their chemistry, all catecholamines have three properties in common. First, they cannot be used orally. Second, they have a brief duration of action. And third, they cannot cross the blood-brain barrier. So next, guys, we have the non-catecholamines. The non-catecholamines have the ethylamine in their structure but do not contain the catechol moiety that characterize the catecholamines. So next, we have the non-catecholamine. The non-catecholamines have the ethylamine in their structure but do not contain the catechol moiety that characterizes the catecholamine. So three non-catecholamines are ephedrine, albuterol, and phenylephrine. So next, as you can see on the screen, guys, the catecholamines are so named because they contain a catechol group and amine group. The amine component of catecholamines is called ethylamine, while the non-catecholamines have ethylamine in their structure but do not contain the catechol moiety that characterize the catecholamines. So guys, next, on the next slides, we have the different medicine or drugs under the catecholamines and non-catecholamines. So I'll just leave the presentation on so that you can read by your own, and also you can take down if you want. You can just pause the video. So for these medicines, guys, or drugs, we have the receptor specificity, chemical classification, pharmacokinetics, adverse effects, and preparation, dosage, and administration. Note, guys, some of the drugs here I didn't put the therapeutic use. Next, we have the adrenergic antagonist. So, adrenergic antagonists cause direct blockade of adrenergic receptors. With one exception, all of the adrenergic antagonists produce reversible or competitive blockade. Unlike many adrenergic agonists, which act at alpha and beta adrenergic receptors, most adrenergic antagonists are more selective. As a result, the adrenergic antagonist can be neatly divided into two major groups. First is the alpha adrenergic blocking agents, or the drug that produce selective blockade of alpha adrenergic receptors. Second is the beta adrenergic blocking agents, or the drugs that produce selective blockade of beta receptors. So guys, next we have the also different uh, drug under the adrenergic antagonist, which are the prazosin, terazosin, doxazosin, tamsulosin, alfazosin, silodosin, phentolamine, and phenoxybenzamin. So I'll also just leave the presentation as what I did kanina. And then also you can also take down notes if you want, guys. Just pause the video. So guys, and under the adrenergic antagonist, we have two, which are the alpha adrenergic blocking agents and the beta adrenergic blocking agents. So I'll just leave the presentation on for this chapter. So for the following slides, guys, you can see the different drugs under the alpha adrenergic blocking agents and the beta adrenergic blocking agents. You can also, guys, see the preparation, dosage, and administration for alpha adrenergic blocking agents and for the beta adrenergic blocking agents, guys. So guys, we are in our last chapter, which is the indirect acting anti-adrenergic agents. So it is the drugs that prevent the activation of peripheral adrenergic receptors, but by mechanism that do not involve direct interaction with peripheral receptors. So there are two categories of indirect acting antiadrenergic drugs. The first group, centrally acting alpha-2 agonists, it consists of drugs that act with the central nervous system to reduce the outflow of impulses along sympathetic neurons. The second group is the adrenergic neuron blocking agents. So it consists of drugs that act within the terminals of sympathetic neurons to decrease norepinephrine release. So for the following three slides, guys, it consists of different drugs under the indirect acting antiadrenergic agents. So those are the clonidine, methyldopa and methylidopate, and the reserpine. So I'll also just leave the slides, guys, as it is, and then you can pause if you want for you to read and take down notes if you guys want.